My name is Tomislav Majic. I'm from Berlin, where I'm working as a psychiatrist in a clinic for psychiatry and psychotherapy. I'm very happy to be here in London for the first time. This is the first talk that I give in English, so please excuse me for my poor English. I was invited due to a review article that I published together with Timo Schmidt and Jürgen Gallinat this year in Journal of Psychopharmacology, where we reviewed the literature regarding the question of how psychedelics could act as therapeutic agents. I would like to present you some of the ideas that evolved through this process. So first I'll say something about the substances which are used in psychedelic assisted therapy. Next I will say something about past and current concepts of how psychedelics have been used as therapeutic agents. Then I'll say something about the indications with a special consideration of the possible mechanisms of action for therapy. And before I come to the conclusion, I will say something about ketamine and its different paradigms in psychiatry, because I believe that ketamine is an excellent example to illustrate the variety of different approaches to psychedelics in therapy. So, which substances have been used in substance-assisted therapy? Above all, the classical hallucinogens like LSD, 25, mescaline, psilocybin, DPT and other tryptamines have been extensively investigated in the first golden era of clinical psychedelic research. A little bit later, atypical hallucinogens like ketamine have also been used in ketamine psychedelic therapy, mostly in Russia. Entectogens or empathogens like MDMA and MDA have been used since the 1970s in substance-assisted therapy, since they have been promoted by Alexander Shulgin as a window to the soul in the psychotherapy process. Recently, there are studies with promising results in the treatment of post-traumatic stress disorder by Michael Miethöfer and other authors. It has also been mentioned that other non-psychedelic substances like oxytocin, the hormone oxytocin, and the antibiotic cycloserine have been used or are currently being investigated in the context of substance-assisted therapy, mostly of anxiety disorder like post-traumatic stress disorder, general anxiety disorder, and social phobia. It's of historic interest that in the 1950s to 70s, also other substances like barbiturates, amphetamine, and nitrous oxide have been used in this context. So how are psychopharmacons in general used in the treatment of mental disorders? In traditional psychiatry, a substance is used or substances are prescribed in order to treat mental illness, and sometimes this has reflected like ideological struggle, because some psychiatrists believed that mental disorders are of a biological origin and only medicaments, only pharmacology can help them, and other psychiatrists who believe that these disorders are more of a psychosocial origin believe that these disorders should be treated primarily with psychotherapy. So what we have today is that both these mental illness, or a lot of type of mental illnesses are treated in a process combining psychotherapy and pharmacology, as in major depression, where antidepressants are prescribed, and at the same time psychotherapy is carried out. In this approach, there's no explicit relationship between the these two processes. Some therapists even believe that the medicaments should be prescribed by another person in order not to disturb psychotherapy process. So one physician or psychotherapist does psychotherapy, and the other one prescribes the medicaments. In all the different concepts of substance-assisted therapy, the administration of a psychotropic substance has a specific purpose in the framework of the psychotherapeutic process. So the different forms of substance-assisted therapy differ above all regarding the type, intensity, and frequency, how how psychotherapy and pharmacology are related to each other. In this sense, substance-assisted therapy practically points to something like a missing link between biological and psychological models of mental illness and human consciousness in general. When we consider psychedelics in the context of therapy, we have to remember that there are different temporal dynamics regarding the subjectively perceivable effects in the patients. So first we have the acute effects like the psychedelic states with a duration of hours to days, which has been extensively described by different authors already. Then we have the subacute effects, which have been sometimes named afterglow period or after the afterglow phenomenon. For this period, an elevated and energetic mood has been described in the patients or subject using psychedelics, where they're relatively free from sorrows about the past, from feelings of guilt and fear, and with an enhanced willingness to engage in social relationships. For this time frame, an enhanced effectivity of psychotherapeutic intervention has, for weeks or 2 months, has been also reported. And we have the residual effects that what we learned in the previous talk by Tamara and Elena, which we know from the Good Friday experiment also, where mostly positive effects are reported for patients even after years after the last use of psychedelics. When considering, it's also important to mention that the idea to use psychedelics as medicines originated in ritualized contexts, in like shamanic contexts or others where there's no psychiatry and no psychotherapy, and in fact that these are very old concepts or very old ideas that we're changing or adapting to our times. When recapitulating the variety of therapeutic approaches that were applied, you can boil them down to 2 different basic ideas to be distinguished. In one approach, the substance is administered in order to intensify an ongoing therapeutic process. This is what happens in psycholytic therapy, medication-enhanced therapy, or MDMA-assisted therapy of PTSD. In other words, the focus is on the inherent effects of psychotherapy, which are enhanced by a substance. The other strategy is to put the effect of the substance itself in the focus, as in psychedelic therapy. It has to be emphasized that one of the central aspects of why psychedelics became so fascinating for psychiatrists in the 1950s was the fact that they were interpreted from a predominantly psychological viewpoint. Stanislav Grof suggested that there's no single effect which occurs like in every session, in every subject, and that they're highly suggestive. In other words, almost all types of phenomena occurring under psychedelics were interpreted as psychological effects, transcending the barriers of physical determinism. In current concept or in current paradigms, we still have those 2. We don't have this very strict distinction between psycholytic and psychedelic therapy, although they still exist in some way. But the paradigms have been like expanded by other paradigms, as the behavioral paradigm and biological paradigm. the following, I'd like to elaborate on several psychiatric conditions for which the treatment of psychedelics has been proposed, and for which already data exists. I will put a specific focus on the differentiation of those potentially beneficial effects, of which beneficial effects could rather be assigned to pharmacological or rather the subjective experience the patients undergo when they take the drugs. So, the treatment of anxiety and depression in patients suffering from terminal somatic illness has been among the most promising indications for the treatment with psychedelic-assisted therapy. Initially, the concept arose from attempts to reduce pain in cancer patients. So this happened in the first half of the 1960s in anesthesiology, like Eric Cast and co-workers. Analgesic effects of LSD were observed, which outlasted the acute effects of opioids. Surprisingly, although not directly intended, patients gained profound insights, changes in attitudes towards self, others, pain, and death. The reduction of the anticipative cognition of death and the enhancement of immediate sensory life has been suggested as a potential mechanism of action in this condition. The studies this idea was systematically investigated with the use of LSD and DPT until the mid-1970s in Spring Grove Hospital by Stanislav Grof and others. Recently, there have been at least two promising studies with psilocybin by Charles Grob from LA and Peter Gasser, who worked with LSD in these patients from Switzerland. Addiction is the other very intensively investigated condition which has been investigated for the treatment of with psychedelic therapy, which has also been connected with psychedelic peak therapy as the palliative approach, as in the palliative approach. Originally, the idea to treat alcoholics with LSD arose from the observation that LSD could induce states resembling delirium tremens, which is like a part of the alcohol discontinuation syndrome, and which has been reported to be a very uncomfortable state, and that sometimes patients who had experienced delirium tremens had afterwards quit drinking. So the idea was to induce an aversive but controllable and spontaneously reversible state to help people quit drinking. Instead, surprisingly for the authors, the patients who received mostly high dosages of LSD had thought-provoking experiences, mystical or peak experiences, and which changed their attitude, sometimes changed their attitude towards drinking. It has often been mentioned in this context that the founder of Alcoholics Anonymous compared the effects of LSD to his previous mystical experience, non-drug-induced mystical experience, which had made him quit drinking. Another indication which has been investigated with psychedelics is obsessive-compulsive disorder, or OCD. This is very interesting because Stanislav Grof and other authors from the 1960s and 70s mention OCD as a condition which is highly resistant even to high dosages of LSD, and that these patients did not appear to be all too promising for the treatment. Grof reports that all these patients needed dosages for up to more than 1,000 micrograms of LSD to have any psychedelic effects at all. This appears also be true for people with a highly rationalist personality structure and with high emphasis of structure and control. There's a case report from the 1990s where a patient with OCD recreationally used psilocybin, mushrooms containing psilocybin, and experienced a decrease of OCD symptoms. Afterwards, he continued using psilocybin daily for like 2 years, experiencing tolerance to the effects. He didn't have any more psychedelic effects in this time, but with a stable reduction of OCD symptoms. When he quit psilocybin, like after 2 years after the last dosage of psilocybin, the OCD symptoms came back. So there's one famous study from 2006 by Moreno and co-workers who tried psilocybin in 9 treatment-resistant OCD sufferers, and who showed all patients showed a reduction of OCD symptoms, which didn't last too long, unfortunately, but all of them showed a response, which was associated with time, but not associated neither with dosage nor with the intensity of the experience. PTSD, MDMA and PTSD is another condition which has been investigated. PTSD, post-traumatic stress disorder, is characterized by disinhibited and uncontrolled fear reactions. So in behavioral therapy and conventional behavioral therapy of PTSD, the induction and extinction of this uncontrolled fear response is achieved by exposure, systematic exposure to traumatic experiences with an adequate level of emotional arousal. Sometimes this is difficult because the reactions can be so strong that patients dissociate during the sessions, during the therapy sessions, or the emotions are so strong that extinction cannot be achieved. So the rationale for using MDMA in the PTSD was that, or the idea was that MDMA reduces fear in this certain situation when you induce fear responses by remembering old traumatic experiences to improve the bond between therapist and patient, and to widen the optimal arousal, which has been called the optimal arousal zone, or the window of tolerance between sufficient emotional involvement and overwhelming fear response. And there are also biological aspects, as there's a very strong stimulation of serotonergic receptors, and hormones like prolactin, oxytocin, and cortisol are increased after administration of MDMA. Oxytocin is believed to be responsible for the therapeutic alliance and reduction of fear response, and prolactin might be responsible for increased relaxedness and receptivity in this certain process. Now, even if depression is the most common of the psychiatric disorders, there are only a few and controversial findings regarding the treatment of depression with psychedelics. In the first period of psychedelic science, it has been reported that psychedelics might rather fixate or aggravate the present depressive cognition and mood than improve it. In contrast, in the last years, there's a large body of evidence for the treatment of depression with ketamine, and studies with psilocybin are also on the way. So what is ketamine? Ketamine is an NMDA receptor antagonist which dosage dependently exhibits different psychotropic properties. It's a dissociative anesthetic. It's a psychotomimetic or psychedelic or dissociative substance, and it's an antidepressant substance also. So we have different paradigms of using ketamine in psychiatry, which is the psychotomimetic paradigm, like investigated in the framework of model psychosis, then the antidepressant paradigm, as ketamine has very strong and rapidly acting antidepressant properties, and the psychedelic paradigm used, as I have already mentioned, by psychiatrists in Russia, Yevgeny Krupitsky, and others. And ketamine is also used in a recreational context. That's why it's also interesting for addiction medicine and in veterinary medicine, like you see here. So in these different ketamines, when we come back to the different time frames of the subjectively perceivable effects of psychedelics, the different paradigms can be associated with different time frames and different periods of the effects. In the psychotomimetic paradigm, which is being used in basic schizophrenia research, you give a bolus, then a continuous infusion of ketamine to have high plasma levels, so to have this dissociative psychedelic hallucinogenic effects. And the time frame which is focused on the acute effect of ketamine. It's like minutes until the immediate effects subside. And the relevance of subjective effects, it's in the center of interest. In the antidepressant paradigm, there's no bolus given. There's a continuous infusion at lower dosages than in the psychotomimetic paradigm. The time frame which is interesting here is subacute. It's like up to 7 days. And as there's a very good response to the effects of ketamine, but in most of the patients, the effects subside after 7 days. So the immediate effects, like the psychedelic effects of ketamine, are not relevant in this context and unwanted side effects. In psychedelic, ketamine psychedelic therapy, ketamine is given intramuscularly to have a long period of duration, the acute effects, and both the acute effects are used in a special setting, and you focus on the mid to long-term effects of ketamine. There's a high relevance of subjective effects. And then in the recreational setting, all different kinds of administration routes are used. The time frame which is in the focus is the acute, and it's in the party context, and subjective effects are also highly relevant. So I come to the conclusion, in how far are psychedelic experiences relevant for the therapeutic effects in these different conditions? As I have shown, it's probably not relevant in the treatment of OCD, as they were not associated, the effects on OCD symptoms were not associated with psychedelics experiences. The same is true for cluster headache, where non-psychedelic substances which are structurally close to LSD and psilocybin also work energetically. In addiction, the treatment of addiction and depression, they may be relevant in some substances or in some contexts. Maybe there's both effects, a combination of consciously experienced psychedelic effects and biological effects, which are therapeutically effective. And there's other indications like palliative therapy, neurosis, personality disorder, PTSD, where the psychedelic effects are most probably highly relevant for improvement. So, in summary, what I wanted to point out is that past hypotheses on how psychedelics act in therapy have not been left. They're still there, but they're expanded by additional concepts. There's not only a broad variety of psychedelic experiences, but also many different therapeutic mechanisms of actions which have to be considered. These mechanisms differ with different indications, and psychedelic experiences appear not to be always necessary for therapeutic effects. Thank you.